Hi, my name is Brittany Novak. I'm a student pharmacist at DeVille University, and my journal club today is on the efficacy of rosuvastatin, amlodipine, and aspirin in the treatment of hypertension with coronary heart disease and its effect on platelet aggregation. This article was published by the National Library of Medicine. I chose this article because we learned about cardiology in our past pharmacotherapeutics course, and I found it interesting and wanted to learn more about this topic and different treatment options and how it could potentially benefit a patient with other disease states. The title was The Efficacy of Rosuvastatin, Amlodipine, and Aspirin in the Treatment of Hypertension with Coronary Heart Disease and its Effect on Platelet Aggregation. The authors of this study included Giuliani Fu, Ting Wang, and Bateo Li. This study looked at the efficacy of the drugs rosuvastatin, amlodipine, and the Zinn-Hawkes recipe in the observational group, or rosuvastatin, amlodipine, Zinn-Hawkes recipe with the addition of aspirin in the experimental group in treating hypertension with coronary heart disease, as well as how it affected platelet aggregation. The Zinn-Hawkes recipe is used as adjunct therapy. It is a TCM preparation, which is a synthesized mixture of species that improves the outcomes and management of hypertension and coronary heart disease that is being used in the hospitals for the patients who are being treated. The primary outcome of the study was to compare the usage of amlodipine and rosuvastatin alone in comparison with receiving amlodipine rosuvastatin with the addition of aspirin of the course of 3 months to compare the benefit it has on hypertension, coronary heart disease, and platelet aggregation. This study was a prospective parallel group, randomized 3-month study period. Subjects were randomized by using an online web-based randomization tool. A group of 60 patients was randomly split into 2 groups, 30 patients in the observational group and 30 patients in the experimental group. Patients in the observation group received rosuvastatin 10 mg daily and amlodipine 5 mg daily. The experimental group received the same treatment as those in the observational group, except they received an addition with aspirin 300 mg enteric-coated daily, and after a month the dose was reduced to 100 mg daily. Out of 30 patients in the observation group, 18 were male and 12 were female. The ages ranged from 42 to 81 years of age, and of the 30 patients in the experimental group, 20 were male and 10 were female and ranged from 44 to 80 years of age. Inclusion criteria included patients with a clinical diagnosis of hypertension and coronary heart disease, who were aware of the study and decided to participate voluntarily, with complete clinical data, without other drug treatments, without malignant tumors, without abnormal liver or kidney function, without secondary hypertension or cardiomyopathy, without serious metabolic diseases, not in pregnancy or lactation, and with no contraindications to the use of drugs that were used in this study. Exclusion criteria included who could not comply or were unable to cooperate in the study, with abnormalities in coagulation and immune function, with mental illnesses or those who were unable to communicate normally, and patients with severe disease in other organs. The length of the study lasted 3 months. However, the study was open between January of 2020 through May of 2021. In this study, of the 60 individuals, outcome measures were monitored, included clinical effectiveness, blood pressure indicators, blood lipid indices, plasma viscosity, platelet aggregation, cardiac function, and adverse responses after the 3 consecutive months of treatment. The final study was a per-protocol study because it only included participants who followed the protocol, with an alpha set at 0.05. Power was calculated for the primary outcome measure with 60 patients, 30 per group, required to achieve a power of 80%. The original sample size calculation estimated that 100 patients in each group would be needed to detect a 3-point difference between each group in a 2-sided significance test. Therefore, the power was set but not met. When compared between the experimental and observation group, The clinical efficacy of the experimental group was considerably higher. Prior to treatment, there were variations in the blood lipid and blood pressure values between the two groups. The blood pressure values in the experimental group were, however, considerably lower after treatment than those in the observational group. Following therapy, the experimental group's blood lipid indices, plasma viscosity, and platelet aggregation were considerably lower than those of the observation group. After treatment, patients in the experimental group's left ventricle ejection fraction were considerably higher than that of patients in observation group. And between the two patients group, there was not a significant difference in the occurrence of adverse events. The two groups experienced similar side effects at similar rates. None of the side effects were severe. The most common side effects that were seen included dizziness, fatigue, nausea, and constipation. However, there were no major adverse reactions between the different treatments. The authors proved efficacy of rosuvastatin, amlodipine, and aspirin significantly reduces the blood lipid, plasma viscosity, and platelet aggregation indices in patients with hypertension and coronary heart disease, improves left ventricle ejection fraction, and has a high level of safety. Some strengths included the biostatistical test of the study was appropriate. They used valid outcome measures, inclusion and exclusion criteria were adequate. The study was randomized, the doses were appropriate, and the author's conclusions were supported by the results. In terms of limitations, the power was set but not met. The cases in the present study were obtained from inpatients in the cardiovascular medicine department of their hospital, which is a single source and a small sample size. Observation period is short, resulting in limitations in the clinical results. Additionally, this report lacks animal testing to specify which therapeutic target the combination of these three medications is based on, indicating a lack of a stronger scientific basis. For this reason, future studies will increase the total amount of cases included and the sample size, as well as create more indicators, lengthen the observation period, and conduct a follow-up analysis to collect a more complete data. This was a level 2 with major limitations. Therefore, I recommend the usage of amlodipine rosuvastatin with the addition of aspirin, compared to amlodipine and rosuvastatin therapy alone, based on the following justifications. This well-designed level 2 trial with major limitations showed that the plasma viscosity and platelet aggregation of patients in the experimental group with a total efficacy of 97% were considerably lower compared to the observation group with a total efficacy of 77%. Therefore, this proves that rosuvastatin, amlodipine, and aspirin are more effective at reducing blood pressure, blood lipid values, when compared to just using rosuvastatin and amlodipine alone. In addition, aspirin has remarkable effectiveness in the prevention of thrombosis in patients with coronary heart disease. In terms of safety, aspirin did demonstrate beneficial usage in addition to the therapy based on the experimental group. In the observation group, there was a 10% incidence and a 13% incidence of adverse reactions in the experimental group. Therefore, there was no significant outcomes in terms of adverse reactions between the two of them. According to Redbook Online, the cost for a 1,000-tablet bottle of amlodipine, the WAC package price is $14.75. For rosuvastatin 10 milligrams for a 90-bottle count, the WAC package price is $12.14. Aspirin 100 milligrams, the WAC unit price is $6.40. Therefore, all three of these medications are affordable for the patients. For special considerations in populations, this must be administered in a hospital between the ages of 42 to 81 years of age, patients without abnormal liver or kidney function, without serious metabolic diseases, not in pregnancy or lactation, with no contraindications to the use of the drug that were used in this study. If you have any questions about my journal club, you can email me at novakb11@dyc.edu. Thank you for listening to my journal club today, and I appreciate your time.